In this talk, I'm going to go over basically what brachytherapy is. I'm also going to tell you sort of what the changes have happened over the last 30 or so years that we've been doing prostate brachytherapy, because I think that's pertinent. Just in the same way that surgery's got much better and using now robotic surgery compared to open and compared to laparoscopic, we've made similar changes when we do prostate brachytherapy. I think what's important, we're going to look at some comparative clinical results between surgery, external beam and brachytherapy, and then talk a little bit about where we're going with this with high-risk patients and some of the research that we're doing, and maybe round up with just a little clinical case and some conclusions. So why are we bothering with brachytherapy? It's certainly just slightly more technically difficult than just giving maybe external beam radiotherapy. And the reasons for this is that we know prostate cancer is very sensitive to the amount of radiation dose that we give in terms of chance of cure. And dose is more easily given if you put the radioactive sources into a gland as opposed to shining it from beams from outside. And if we increase the dose, we improve our cancer outcomes. And if we get the dose just in the right place, without treating too many of the normal structures around it, we improve quality of life. And we found that with combination treatments, we found it adaptable for most stages of prostate cancer. So brachytherapy has been used in medicine for over 50 years. Mainly, it's been used in cervical cancer. And the reason for this really is that here's the cervix. It's very accessible for putting radioactive sources in. So don't need anything very technical to dilate the cervix, put a radioactive source and combine it with external beam. And as I say, we've been doing this for 60 years. Now, the reason we haven't been doing that with prostates is that to access the prostate, you need some good ultrasound techniques to be able to image the prostate, be able to direct the radioactive sources into the gland. And that's why we in medicine haven't just been grown up thinking this is just standard treatment. Now, I'm not going to put too many data slides up, but these are some of the randomized studies that show prostate cancer is susceptible to the doses. And in this column here, we have randomized studies with different external beam doses. So the first main study that was shown by Pollock from the MD Anderson looked at 78 versus 70 Gray. Now, not great differences doses, but you can see that the outcome in biochemical free survival was quite advantageous. It was 70% versus 45% control. And in that same study, on the left here, there is the disease-free survival. So this is the 78 Gray curve, and 78 Gray is the dose that most centres in the UK use. So if you're talking to somebody having external beam in this country, it will usually be in standard fractionation between 74 78 Gray. So you get a significant difference in biochemical free survival. But what's more important, if you look at the high dose rate, this is the risk of having metastatic disease, i.e. probably needing to go on long-term hormones. And the patients getting 78 Gray had very few metastatic events compared to 70 Gray. So we know, without doubt, dose is important in cancer control in prostate cancer. So why brachytherapy? Well, on the left here is a IMRT plan for a prostate. And you can see that the prostate is completely covered by the 78 Gray. But this yellow line that cuts through the rectum here is 50% of the dose received. If you look on the brachytherapy plan, the 50% isodose is very tight to where the prostate is. And this is just a physical effect of giving brachytherapy, that if you have a source anywhere, the dose fall off outside that source is very sharp. The other thing about brachytherapy, because we're putting radioactive sources directly into the gland, you can put the high dose region wherever you like. In this case, we've treated the peripheral zone of the prostate to 217 Gray. So we're giving it another 50% higher than we were prescribing the whole prostate. We can put that bit of dose anywhere. And because you can put it anywhere, you can put it where the cancer is and you can avoid the sensitive structures, which makes it much more adaptable to do while we're in theatre. Comparison, this is brachytherapy in terms of disease-free survival. I'm going to show you data that suggests we can get 90% a cure and disease-free control with brachytherapy. If you look at 78 Gray, and this column down the left-hand side is the biological equivalent. It's not a complete comparison when one talks about Gray in prostate brachytherapy compared to Gray with external beam. You have to make a calculation, but they are equivalent doses. So two terminologies: low dose rate brachytherapy, high dose rate brachytherapy. Low dose rate brachytherapy is low dose rate. It is still a very high biological dose, so it's not low dose, and it's given with a permanent seed implant. The most common isodose is iodine-125, which is used in this country. It has been used, and we have data for over 30 years. It is used as monotherapy or as a boost to external beam radiotherapy. It can be done as a day case treatment, and we've got very good long-term results, which I'm going to show you some of them. HDR is high dose rate. It's still a high biological dose, but it's given as a source that's put into the prostate and removed again. We haven't got quite so much follow-up of that, and most of the data is used in advanced cases combined with external beam therapy. So LDR brachytherapy, in modern terms, started in the 80s. 83, Blasko, Ragday and Grimm in Seattle. And he invented, and his team, a two-stage, this is original brachytherapy, two-stage technique, where the patients would come in either under a light anesthetic or some sedation, would have a detailed scan of their prostate, and they'd have 5mm cuts taken through the prostate to get a volume study. About 5 weeks later, the patient would come back, and during that time, the physicists would cut individual strands. We'd plan it on a dose computer. They'd come in, we'd try and reset up that position again and deliver the plan we've planned, a bit like how we do external beam therapy. The results have held in time. We have changed things. The technique has got much thicker. We've got much better equipment. We've got better imaging. And as such, I'm going to show you that our results and our side effects have decreased with this treatment. So we took that technique and combined it with some other work that had been done in the States, and created a type of brachytherapy that we've termed 4D brachytherapy, which is a one-stage technique. The patients, and I'm going to walk you through this so you understand it. Essentially, the patients come in, have an ultrasound, go home, and then the next time they come in, they just come in and have their implant. They don't need a two-stage. We use a nomogram to calculate how we order the seeds, and essentially we use stranded seeds around the outside of the gland and loose seeds in the middle to build up the dose. So the procedure starts with a simple outpatient ultrasound, which most of our patients get anywhere, and we take measurements of height, width, length, and as well as doing this, we check their flow rate, we check they're emptying their, they haven't got too many urinary symptoms. We use those measurements to select a plan that we worked out from about 1,000 cases before this, where we would decide how many strands we needed around the outside of this particular size and shaped gland, and then we'd use loose seeds in the centre, and then this is all ordered on the day. The patient comes into theatre, anaesthetic that takes anything between 30 and 40 minutes. And in theatre, we have the ultrasound as we had before, But connected to this stepping device where the ultrasound's resting is a planning computer, a 3D planning computer that we're going to build the dose up during the procedure. And in this way, during the technique, we know exactly how much dose and where that dose goes. So this is Stephen and I in theatre. We take this, while the patient's asleep, we take that same planning scan. We load that planning scan up onto the planning computer. From the nomogram that we already have, we select where the peripheral seeds, strands go and needles that build up the outside dose. These are then marked onto the ultrasound, and we insert, one of us inserts these needles halfway up the gland. And you can see here this horseshoe of needles coming out of the template. And here is an ultrasound of the prostate in the mid-gland, and these little white dots are these peripheral needles. We haven't loaded the seeds yet, we've just left them halfway into the gland. We then insert each needle, and as we do, you can see the needle in the longitudinal view here now. So this is the bladder here, this is the prostate, and this is the needle just lying in the prostate. And as we insert the radioactive material, the person running the ultrasound here marks where these seeds have been inserted. We continue until we've inserted all the radioactive material in the periphery of the gland. There's about 5 minutes of planning for the internal seeds, which at the moment we're using loose seeds, which we can accurately place in order to build up the dose in the middle of the gland, but avoiding the urethra and the nerves that run just distal to the prostate. And what we end up with is this dose plan with these radioactive seeds around the periphery of the gland. This is the catheter running down the middle, and you can see that this is relatively spared from the high dose radiation. This is why we can control some of the urinary side effects that we get, although patients do get acute urinary side effects after this because of the dose that the urethra receives. So in order to show that the technique has improved, this is each of these little dots here represent a patient, and they're what we call post-implant dosimetry. So after every implant, patients go and have a CT scan. We replan them again, and we work out how much actual dose did that prostate receive. And just looking at the dose that 90% of the prostate got, which is this graph here, this is the old technique where there was quite a spread round our optimum dose that we're trying to receive. This is the new technique, so everything is much tighter in all these curves. So we are much more sure, because we've got a planning computer in theatre and because we're doing it in one stage, where the dose goes. And this is important, because what we've shown is that if you reduce the dose to some of the structures outside, you start to improve the long-term outcome in terms of side effects of our patients. This is a study that we published in the Green Journal, and it's just looking at our patients' potency 12 and 24 months after brachytherapy. Group 1 was the Seattle technique, and at 12 months, on average, 65% of the patients were potent, and at 24 months, 61%. And this compares to Group 2, which is the modern technique, where the figures have significantly improved to 85 and 83. Now, it's not randomized data. We can't randomize it because we've sort of moved on from what we're doing, but it does imply that as our techniques improve, then the side effects that our patients are experiencing decrease. And our results we keep, obviously, like all large centres, in a prospective database. This is data from over 3,000 patients that we treated since 1999. All our patients on the left here, and you can see just over 80% disease-free survival out at 15 years. If a split into risk group it varies from about 88 to 82%. Of course, these are highly selected patients. None of these are high risk. None of these are node positive prostate cancers, but some of them are locally advanced. Some of them have PSAs greater than 20, T3 disease, Gleason 9 and 10. So they are doing actually incredibly well. So that's our brachytherapy experience. But when a patient comes into clinic, they've got to decide, what am I going to have? If you've got local prostate cancer, or localized prostate cancer, your two tried and tested modalities of treatment with over 10-year follow-up is either high-dose radiation, be it brachytherapy, external beam, or having a radical prostatectomy, which may or may not need to be followed by external beam radiotherapy. Now, there has been one randomized study between brachytherapy and radical prostatectomy. Unfortunately, it had to close early because we couldn't manage to recruit, because I think it's just difficult for a patient to randomize between two such different treatments. And these are the results. Believe it or not, there are two lines here. This is disease-free survival between the group 1 and group 2, and they are absolutely identical out at 5 years. There is no difference in disease-free survival between having radical prostatectomy and brachytherapy in early prostate cancer. Because there aren't randomized studies, we have other comparative studies where we've tried to compare like with like. So we've tried to put together patients in big cohorts who've got long-term follow-up, who've had either good quality prostatectomy, good quality external beam radiotherapy, good quality brachytherapy. And this study that gets regularly updated was last published in the BGUI. And I'm just going to show you the cohorts that either had surgery or brachytherapy for low risk, intermediate risk and high risk. And I'll just show you what we're looking at here. This on the left-hand side is the percentage-free, PSA-free survival. This is years, and each of these dots represent an individual study. If they're blue, they're brachytherapy. If they're red, they're surgery. And these lines drawn around them are a statistical comparison to try and lump the two treatments together. And as you can see, if you're low risk, the results are similar. I mean, it's difficult to say. I suppose brachytherapy is a bit better, but again, these aren't randomized. As soon as you start to get to intermediate and high risk, and this is surgery, brachytherapy, brachytherapy with external beam radiotherapy, and high risk, most of them are getting external beam radiotherapy and brachytherapy, but compared to surgery alone, there's quite a big difference. And I think what you can say from this data, and there's a lot of data there because each of those are individual studies, there is no appreciable difference in terms of your chance of cure with high-dose radiation using brachytherapy, either in combination with external beam or not, compared to surgery. And in fact, if you have the more advanced disease, the trends are that you are getting better control. There are several other studies who have looked at this. Niels Arvold in Journal of Urology concluded that there was no difference in mortality. And I think just more importantly, last year in the European Journal of Cancer, there was a systemic review of as many studies as they could, similar, and their bottom line was that if you're giving high quality brachytherapy, external beam radiotherapy or radical prostatectomy, your chance of dying of prostate cancer is the same. And I think that's very important when you're talking to your patients, that they do have a choice, and some people will prefer one or the other. But you can, I think with your hand on your heart, say, well, there isn't, you're not going to be better off in terms of living to 90 with one treatment or the other. I think the other question that's always come about any radiation treatment is, well, you haven't taken the prostate out. Are you going to get more late recurrences? And it is something that concerned us. We didn't start brachytherapy till it was after 10 years follow-up, but it is heartening, and there's two studies that show this, that Ragday looked at his 12-year data with brachytherapy, and found that out of all those patients that failed, 25% failed after 5 years. Interestingly, Pound from New York, who wrote the biggest series of radical prostatectomy, also found 23% of their failures happened after 5 years. And it's the reason people fail after 5 years is probably because there's a few microscopic metastatic disease outside the prostate already. And these micrometastases grow, they start producing PSA, and you get a PSA failure. Much the same as we see in breast cancer. And patients fail at breast cancer between 5 and 10 years, and we are now, as we get better control of prostate cancer, we're seeing the same. So, if we think that the survival is the same, what are the other things that patients are concerned about? Well, obviously side effects of treatment. Again, difficult to get randomized data, but this is randomized data. This was from that same 200 patients who had surgery or brachytherapy. And this is urinary leakage, and perhaps not surprisingly, these bar charts, blue is rarely or never urinary leakage, yellow is about once a week, and you can see in the brachytherapy cohort it is very rare to get urinary leakage. With surgery, actually it was slightly harder than I'd expect. I would have thought that would have been more like 10%, but in fact 30% of people were still getting significant urinary leakage. As far as erectile function, same again, this is that randomized cohort. If you look on the graph here, good or very good is blue, this dark blue is fair. So in brachytherapy, 70% of people are getting fair erections. After radical surgery, that's only 40%. So randomized data suggesting that potency is significantly better after brachytherapy. There is other non-randomized data that do show similar results. This is probably the biggest of them. It's from Talcott in the States. And he looked at radical prostatectomy and split those patients up into nerve-sparing, non-nerve sparing. He looked at patients with brachytherapy and with external beam radiotherapy. Similar graphs. Sexual dysfunction, somewhat surprisingly. So again, normal is yellow. Blue is intermediate. There didn't seem to be a great difference between the surgical non-sparing, nerve-sparing or non-nerve-sparing, again, intermediate and normal are about 30%. Brachytherapy, it's getting consistent, is about 70% of people are retaining their potency if they were potent beforehand. Incontinence, we see similar to what we saw in the other quality of life studies, where external beam brachytherapy, rarely incontinent. We do see a difference in bowel problems. Any radiation technique does cause some bowel symptoms, and the surgical arm does have significantly less bowel symptoms, although intermediate, there's not very much difference between all groups. We've shown that the quality of life is probably a bit better with brachytherapy. Survival's the same. Interesting cost effectiveness. There's not very good data from the UK. There was this ISA document from the States, and they had as their baseline radical prostatectomy. And everything costs different in the States, and external beam is extremely expensive. And I think the only point is if you take reference point as a radical prostatectomy, a brachytherapy implant is about $2,000 cheaper, whereas proton beam, IMRT, or even active surveillance is significantly more expensive. I don't know that you can draw direct comparisons to the NHS because we've got, we already have our external beam radiotherapy machines, but they have to be serviced, they have to be bought, so all that needs to be factored in. So that's standard fare for brachytherapy and up to now really, and radical prostatectomy. Early prostate cancer, active surveillance, radical treatment. I think where we're going now with brachytherapy is moving into the more high-risk disease, and this is a randomized study that's due to be published in the next few months, and it was performed in Canada, and it's one of the most important studies that we've had in oncology, and particularly in prostate cancer oncology, for some time. And it was a multi-centered randomized study, and it compared patients getting 78 Gray with external beam radiotherapy plus hormone therapy, and this was delivered as 46 Gray to the whole pelvis, and then an external beam radiotherapy boost to the prostate gland to give 78, compared to 46 glands to the pelvis with a brachytherapy boost to 115 Gray. So they were fairly equivalent doses in many ways. However, probably because what I told you before, that you can get this very high dose area within the prostate, this is the overall result. It shows that the PSA-free survival for the 78 Gray patients, and remember in this country a lot of people are still using 74 Gray, and nobody as far as I know is using more than 78 Gray. You get in these relatively high risk patients a steady decline of your PSA-free survival over 10 years, where with the higher dose brachytherapy arm you're getting this levelling out, indicating that if you give enough dose to these patients, you're going to see better overall control. And we've seen from Pollux data that if you start seeing this, we're probably going to see less metastatic disease as well. You can see this both in the overall and in the intermediate and high-risk group. Overall survival isn't different. Now, I would say that we just haven't got long enough follow-up to see overall survival in prostate cancer. I think the big question is how many of these patients who are failing have already been put on androgen deprivation and are somewhat suffering from the quality of life issues that are associated with androgen deprivation. I think we need further follow-up just to find out whether this is going to translate into a survival advantage. So, research. Brachytherapy has been around for a long time. I think what we're looking in all realms of prostate cancer is to minimise side effects from treating what could be a non-lethal disease. And just as we've looked at focal therapy in HIFU, we're looking at in brachytherapy in Guildford. We've started a prospective study looking at treating half the gland if the patients are suitable. And these are patients who've had a template biopsy, had an MRI, have only got disease on one side of their prostate. We've sort of adapted our 4D technique to simply plan one side of the gland, and we're comparing it to our cohort of matched patients that we treated previously. This study is ongoing, so I can't give you any results of that, except to state that any focal therapy has to be experimental until we've got long-term survival data. But encouragingly, the PSA fall that we've seen in our patients has been dramatic and perhaps better than we might have expected. So, we haven't talked about selection, and I just want to talk about selection with realms of a clinical case. Because clearly not everybody is suitable for prostate brachytherapy. Many people would wish to have other treatments, and patients obviously have to weigh up, and I think one of the main important factors in deciding whether somebody is suitable for any treatment is that they are given their choices. But if a patient has severe obstructive symptoms, If they have large glands, and large glands probably over 80 cc's would be too large for brachytherapy, although if they are needing hormone therapy, that probably could be downstaged to a suitable size. If they have locally advanced disease where there's significant palpable disease outside the gland or extensive disease in the seminal vesicles, they wouldn't be suitable for brachytherapy. Obviously, previous colectomy, if you haven't got a rectum to be able to get the probe to visualize your prostate. And if you have a large middle lobe that would be actually difficult to get the radioactive seeds in as well, a particular shape of prostate, you wouldn't be eligible. However, there are some patients who have significant urinary symptoms that you can make suitable. And this is a particular case. This man came in. He had very suitable prostate cancer in that he had a PSA of 9.5. He had 3 + 4 = 7 prostate cancer in 3 out of 12 cores. He wanted radical treatment, but he had a relatively small gland of 40 cc's, but he had a very poor urinary flow. He had a max flow rate of 6 mils per second. He had a post-void residual of 160. Now, when you look at his ultrasound, as I said, he had a smallish gland, but he had this protruding ball valve effect of his middle lobe. Now, traditionally, you shouldn't do brachytherapy if you've had a TURP, but you can resect just part of this gland, and so long that the flow rate improves with that, and so long that you don't take too much of this, the blue would be a more traditional TURP, and if you're starting to do that, you can't do brachytherapy because you do need a tissue to put the radioactive sources in. But if you just take the red area, that patient can then be suitable for brachytherapy because you're way away from the sphincter and you're not going to damage the urinary control by giving high-dose radiation to that area. So we did resect this. We did a small bladder neck resection that you can see there on the left. And this is in comparison with the large area that would normally be taken out with the TURP. So if you're doing this, this is always probably best done by the urologist who's going to be interested in brachytherapy beforehand. And we do maybe 10% of our patients, we would look at doing that because if we can optimize their flow rate, they have less urinary symptoms after treatment. This was his flow rate afterwards. And we would wait about 8 weeks before we did the implant. And actually, he had very little in the way of urinary symptoms after his treatment. To summarize, there are a number of different risks in terms of prostate cancer. And these patients need to be treated in different ways. If we have low or low intermediate risk, we would treat with a brachytherapy implant alone. And that would be defined as somebody with a PSA of either 10 to 20, or Gleason 7 or T2B. They don't need hormones, so that we're giving a high enough dose. And unlike external beam radiotherapy, where most people get offered hormones, we try and treat most of our patients without giving androgen deprivation. I think there's good evidence suggests, though, if you have a higher intermediate risk, and these are patients with either Gleason 7 and a PSA of 10 to 20, that having a short course of hormone therapy before their implant is a good idea. And if they're worse than that, for the high-risk patients, then combining the triple modality, as in that Ascend-RT study that I showed you, is it would be our policy treatment. So you can start build up a spectrum of disease, and I think that once we've been really talking about this group of patients here, but there is a further higher risk group of patients who may have nodal disease, and I think that we're starting to see combinations even in high risk patients where we're adding chemotherapy in plus significant time of hormone therapy and then doing high dose radiation. I think we are moving that curve to getting better not only better local control, but I think that is going to impact on overall disease-free and overall survival. So to conclude, I think that the data is out there. It's not a new treatment now. Brachytherapy is effective local treatment. I think the side effect profile of brachytherapy in suitable patients, and not all patients, as I say, are suitable, but if you've got a suitable patient with few urinary symptoms to start with, they do well in the long run. There is a typical 3 to 6 months period of acute urinary symptoms that settle. Most patients are back at their desk within a week or two, and in high-risk patients, combining it with external beam and hormone therapy is applicable. We've been sponsored by a number of people during our time over our last sort of 17 years, and I'd like to thank all our sponsors. Thank you.
Do the majority of patients go to centres? Do most centres have two-stage planning and then implanting?
Yeah, we did actually a survey for the college not so long ago, and it was about it's about 50-50, but I think more people are very much trying to move to a one-stage technique, but there's still quite a few people, well, in the UK certainly. Other countries, Australia, for instance, are almost all two-stage. But I think that the trend is moving, and we would very much advocate a one stage.
I have a couple of questions, but the first one, the slide you showed with where the 50% dose hits, if you have, how does that change if you have targeted an area with a particularly high dose? Then presumably it shifts a bit, and then also you need to look at the 25% dose, because that would be half of the 78.
Yeah, it's a good question. Actually, our 50% and our 100% stays about the same. So because we sort of plan to our 100%. So when we're doing that interactive planning, we plan that the whole prostate gets 145 gray. So we have enough, but within the gland, you don't need to move the source around very much just because a part of the gland always gets 150%. We can't do it otherwise. And by shifting that round a bit, yes, you might get a bit more of a bulge out that side, but it's very minimal just from the actual physical characteristics of radioactive sources. So you can put a couple of extra seeds in the left-hand side, take them out the other side. Your 145 still goes around the whole thing, and by definition, your 50% just falls off exponentially. Any other question?
Yes, I was wondering also the comparison data between all the different types of treatment and the side effects. Does it vary with the age of, like, if you broke that down by the age of the patient, would it change?
I'm not sure that I think that the age of the patient, I don't think makes a difference in brachytherapy. I think it can make a difference in surgery just because of, I think physical fitness is important. More importantly than the age, I think it's your pre-existing symptoms. It depends on what symptoms you have beforehand, probably predict how you're going to get on with any treatment. And there's some people that walk through the door that you just say, look, you just go and have a radical prostatectomy because you've got such bad obstructive symptoms or whatever. But the majority of patients, you could do either treatments on just as well. And I think age is an important factor because we always debate, we see a lot of patients who are in their 50s being referred for brachytherapy. And the bottom line, when you're 50, most people around the world say, oh, you must have a radical prostatectomy. But actually there's no data to say that is the right thing to do. If you look at patients less than 50, and we're just compiling our own experience, several papers written on brachytherapy, they do just as well as older people with it, and the long-term results are good. The risk of second cancers, which is always a risk with any radiation, seems to be very small. A lot of studies with just brachytherapy alone haven't shown a significant increase in second malignancies. I'm sure there must be, but it's so small that it's quite difficult to see. So I don't see a young age as being precluding that you do brachytherapy. And in fact, these, the side effect profile of being able to be potent, being out active, sort of playing tennis and things without leakage makes it actually rather a good choice.
So another question, what about stricture?
Yeah, so stricture formation is a concern. Interestingly, since we've changed our technique, and it's to do with you get a stricture in the bulbar urethra, just distal to the prostate, and it's due to radioactive sources just around that bulbar urethra. We found, since we have changed our technique, because it lowers the dose to the distal part and the bulbar urethra, our strictures have been less. But it does happen, and it's you know, up to about 4%, usually around about the 2-year mark it happens.
It's probably an impossible question because I don't know the results yet, but the PROTECT study is due out at some point soon. What sort of impact do you think that might have on treatment decision and
choice?
And choice?
You know, it's difficult to know until we know what that
Sure.
that shows. But I think what it will show is that patients need to be informed and very much have a choice. And I'd say I suspect the results are going to be fairly similar across the board. But yeah, I think that these look. We need more randomised studies. I wish we had randomised studies in prostate cancer. I personally think more patients should see everybody. Unfortunately, it is the problem across the world is that patients are diagnosed by urologists, and if urologists are very keen on radical surgery, they will influence that patient before they have a chance to think about it. And I think that's where an organisation like this has a large part to play in terms of informing patients, because most, you know, with prostate cancer, you have time to think. You don't have to rush into a treatment.
So, what about a patient who can't have a GA?
Yeah, we do them under spinal as well. So we like to do a GA because actually it's slightly quicker in theatre, but to be honest, we often do them under spinal in that case as well.
Has robotic surgery significantly improved radical prostatectomy outcomes?
Well, I think it's probably made more surgeons be able to do a decent technique. I think there were surgeons who were very good laparoscopic surgeons who probably can do it just as well with and without a robot. I don't actually think any of the published data, as I showed you there today, doesn't, and there's comparative data. Nobody, I don't think more people are cured with it. I think you still need to use external beam if the disease is at the edge of the gland. So I don't think it's made a difference. I think perhaps the standard of surgery is a bit more even across the ground. I suspect there's a less of a difference between good surgery and not so good surgery. But outcomes, it's the same operation. So I don't think it's going to change.
So where patients are being presented with that choice of treatment option, do we know how influential the difference in side effects is, and are they being presented with that information which is helping them to inform that choice? I
think that, to me, that's the most important thing for them to make their mind up. But it's a good question. I think it varies greatly from centre to centre and who's speaking to that patient. And one tries not to be biased. I think we all bring our own biases into any conversation. As I say, I hope that if we have a patient who has equal choice, we let them go away with the information. Usually people know what they want inside, and some people just like the idea of a prostate being physically removed. They know it's not in there. They have a low PSA afterwards. And for them that's the right thing to do. But I think now we've got more and more data to suggest that the long-term outcome's the same. You can, with your hand on your heart, say, look, you do have a choice. It's not going to make a difference to your chance of being a long-term survivor. But all these patients should be discussed in a multidisciplinary meeting, but that's not the same as the patients getting that information. Yeah.
What about supplemental brachytherapy?
After external beam or after?
Oh, sorry, after brachy when there's recurrence in a spot.
Okay, so after external beam radiotherapy, and then if there's a recurrence, doing brachytherapy then?
No, just having had brachytherapy and then a recurrence is seen.
Oh, okay. So the good thing about that is that it is an unusual event, and so if we have somebody with a rising PSA, they all get an MRI, they all get rebiopsied, we look for where that PSA is coming from. The risk of having disease back within the gland is just a few percent. We haven't implanted those patients. We have probably about 10 patients have had radical prostatectomies. And in the same way, if we have a nodal recurrence afterwards, we've had the nodes removed. But people have given supplementary brachytherapy after failure with external beam radiotherapy, where a recurrence has been re-irradiated. I think it's, if you've got a good implant first time, I would like to just get the cancer removed. I fear that it might be a bit more radio resistant. Now, if there's a cold spot in your original implant and then you get a recurrence there, you could in theory re-implant it. We haven't. Now, that's not to say after we do an implant, all patients get a CT scan. We replan them on day one. In about 0.5% of cases, we feel that implant wasn't adequate, and we will bring those patients back to theatre the next week and put a few more seeds in, which is slightly different to what
Yeah.
we're talking about.
Thanks.
I wonder if there's any questions on the VC.
I have one question. I don't know if you can see me or hear me.
Yeah, can't see you, but I can hear you.
Okay, great, thank you, and thanks for a really useful talk. I think I just had quite a specific question about the erectile dysfunction or erectile function graphs that you showed in that randomised report. So where it was like 70% with brachytherapy and 40% with surgery.
Yeah.
How long after treatment was that measured?
I think that was, I think it was either 18 months or 2 years. And
Okay, and I just wondered if there'd been like just that one time point or sort of a time course looking at how quickly it recovers. Maybe not.
Yeah, well, we have done that work, and in fact, we because we have a large database and we've looked at patients every 6 monthly with an IIF score. What you see is in the first 6 months, it tends to decrease and then improves. And so, as you saw from our data, we looked at 1 and 2 years where there wasn't a difference. We published in BGUI data where we compared, we did a postal study of patients we had treated 10 years before, and what was interesting, those patients who retained their potency at 2 or 3 years, the majority of them still retained at 10 years, so it did seem to be durable, because one of the questions is it something that then carries on decreasing, which it does. I mean, as men get older, erectile function does get worse, undoubtedly, but there wasn't actually a significant difference between 5 and 10 years, which was quite heartening.